a very good afternoon to one and all of you, and my special thanks to my moderators on dais. I'll be first taking you on to corneal surface ablation, and we'll definitely ensure there are adequate discussions which follow each of these talks. So we knew that surface ablation has been there for over 2-3 decades, but it has got rejuvenated now because we better understand the biomechanics. What we all very clearly understand is that the anterior stromal fibers have a lot of significant cohesive tensile strength in the cornea compared to the posterior fibers. And again, the peripheral fibers are stronger than the central fibers. And this has to be kept in our minds. And this has been further substantiated by the electron microscopic and the Brillion microscopic study. So basically, when we talk of surface ablation, we are meaning the PRK, which was earlier the conventional one, then the transepithelial one, then the topo-guided PRK, then the PRK extra, then came the PTK, and of course, topo-guided PRK with CXL and TREC for keratoconus patient. Now, why the conventional PRK of manual debridement or using a rotating brush is not that good enough is because the epithelium removal is not uniform. So there could be an asymmetric hydration and also an inaccurate ablation pattern can occur as against a laser transepithelial PTK and PRK being either done in a single sitting at one go or PTK followed by PRK. Whichever way it is done, there is less time consumption, there's less hydration of the stroma, and the ablation pattern is more uniform. We all know surface ablations are largely done for thinner corneas, but again, a normal keratometric reading, but it has a special role where there's an epithelial basement membrane dystrophy or any kind of anterior segment stromal dystrophy or recurrent corneal erosions. But although we prefer to do only up to 6 diopters of surface ablation power correction, there are a few who do a higher correction. And herein what they do is they use mitomycin for a longer duration. And hyperopic class PRK is not very effective, and it is infrequently done because the regression is more because of the curvature change which occurs and the epithelial hyperplasia which can occur in these hyperopic eyes. Again, those patients who are not eligible for SMILE or LASIK procedures, and if they have enough stromal bed, residual stromal bed of 300 microns, we could do a surface ablation. It can also be done as a surface enhancement procedure post PK, RK, LASIK, and SMILE. And when we would not do a PRK is if it is a very low myopia of -1 or less, because there is some amount of epithelial remodeling which is suddenly sometimes can be fallacious, and we may not get that bang-on correction. And if there are certain systemic autoimmune diseases or an ocular inflammation or a history of herpes or any viral infection, we would not do it. And again, we would not do it if the corneal thickness is too low or there are deep stromal scars, vascularization, corneal aesthesia, or steroid responders. So we would do a regular evaluation in corneal surface ablation. We would do an epithelial map. I'm not showing you the procedure, but what we need to know is after we remove the epithelium and do the power correction, when we place mitomycin C, the role of mitomycin C in every single case is it kills the keratocytes and also prevents haze coming in from the migratory keratocytes from the limbus. And largely we use 0.02% for 30 seconds. And there are people who use 10 seconds for each diopter, 10 seconds exposure for every diopter of correction. Then came the PRK contoura, wherein based on a topo-guided measurements which are done, PRK contoura is being done, and it's a highly customized procedure, seems to be in greater accuracy because the maps are done on the cornea and most of the aberrations are on the cornea. And in a topo-guided treatment, what we know is it's a combination of a myopic and a hyperopic correction, which is, and it makes sense. And with the contoura, it is also centered on the visual axis, and there's also pupil centroid compensation. So if you're looking at PRK contoura procedure, basically what is important for us in our selection is the map, ablation profile map of the wavefront guided should be similar to that of the topo-guided map we are generating. So we should take initially number of maps, see whether, and compare the maps. Now here, for this power correction of 2.75, this is the ablation map which you see here. And for the small amount of higher order aberration correction, it is 6 micron. But then This is the final topographic contour map, but we should compare it with the wavefront optimized map to see whether they are similar. If it is very dissimilar, it could be that there are more higher order aberrations on the eye, and correcting them might induce a refractive error. Again, we know that there are certain borderline corneas of patients with pregnancy or allergic manifestations or a suspicious posterior float, etc., wherein you feel that it makes sense to do a PRK extra like Classic Extra or Smile Extra. Essentially, we all know that by doing a cross-linking, what we are actually doing is we are tightening the lamella and strengthening it, and there is flattening of the K. But what is critical is when you're doing cross-linking in a refractive procedure, we do not want a refractive impact to occur. So then what was done with innumerable studies were done, and they decided that using a fluence of 2.7 joules, that is half that of a regular keratoconus patient, and at 30 milliwatts per centimeter square for 90 seconds. 90 seconds exposure to riboflavin and 90 seconds of treatment to ensure that the total energy is 2.7. But there were a few who used different energies and still promised to get good results. What we understand is, if it is in a femto-LASIK extra, there are vertical cuts which are created. In SMILE, a delamination cut is created. This could have a small biomechanical weakening as against surface ablation being combined with cross-linking, which seems to make more sense. It also seemed to make us realize that even those eyes where you're trying higher power correction, wherein there could be more epithelial hyperplasia, doing an extra procedure would tighten the lamellae, give increased rigidity to these eyes. So different studies did tell us that doing an extra procedure makes sense. There's no loss of BCVA. Probably we have to look at it as a prophylactic procedure rather than a therapeutic procedure. And we did a study of about similar number of eyes of PRK against PRK extra for some borderline topographies. But what we found was both PRK and PRK extra, there was stability in the manifest refraction, stability in the K. So then, the other role of surface ablation comes in bioptics. When you do a cataract surgery and a person has a premium IOL implanted and has a small residual error, surface ablation could be an option to go. Again, I'm not showing you the procedure, it's just the regular way it's done. PTK is another mode of surface ablation where you treat anterior corneal pathologies. We can remove only about 100 micron of the tissue, and that is, we should ensure that at least 250 micron of the residual bed is there. We need to do a pre-op OCT, and the indications of PTK are right from corneal degeneration to dystrophy, to recurrent corneal erosion, superficial scars, and old keratitis. This was a case of spheroid degeneration, wherein we did a surface ablation and the cornea stabilized. Sometimes it could be even treated for post-LASIK macro folds or decentered ablations. It has a role. But PTK cannot be done for deep stromal scars, which are vascularized scars, or if the patient has a diabetes or autoimmune disease, or if there is an earlier history of viral infection in the cornea. We also need to understand in PTK there could be a recurrence of the primary disease pathology, like reactivation of herpes simplex virus. There could be a delayed healing of the epithelium and an allograft transplant rejection, etc. And most importantly, sometimes it could induce a refractive error, so it makes sense to even combine it with some amount of refractive correction. The other area where we can do surface ablation is in an early mild to moderate keratoconus. If the patient has a larger coma, a poorer visual quality, and is not comfortable with contact lenses, we need to take on corneas which are at least 450 micron thickness. And the advantage of combining a topo-guided surface ablation regularization with cross-linking at the same time is you are saving the time for the patient, and there's a reduced haze formation because the cross-linking will kill the keratocytes, and because we are disrupting the Bowman's membrane, there's greater penetration of riboflavin. However, when you're treating a keratoconus eye, you can bring the optic zone from 6 to 5.5 millimeter to get a better correction. So you need to check the best 5 maps, and once you have done that, enter the refractive errors. You need to change the whole refractive correction to 0 to understand what is the amount of tissue which is going to be taken away, because we are very specific that we do not remove more than 50 to 80 micron of the tissue. And then this is the kind of map which you get generated here, a myopic with a hyperopic ablation. And you also need to, this is another patient wherein he had a 6 diopter of keratoconus, and we looked at correcting just about 3.75. The anterior float of the treated eye of the eye to be treated should correspond with the anterior float of the keratoconus. And see, the patient had a 3 counting fingers. It came to 660 with significant symmetry of the cornea. Like this is a case of a centered cone which did very well, a decentered cone which did very well. So this gives us an idea that you could treat different kinds of ectasia, like in a post-LASIK ectasia here, which had a -2 diopter of cinema. Look at the irregularity on the topography, flat superiorly and steep centrally. And this is the kind of improvement from 624, the vision improved to an uncorrected 612 and a BCV of 6.6. I'm not going to talk to you about TREC because this is essentially for corneas which are thinner than 450, and in a Schwinn platform, you are able to treat these eyes. I'm not going to go into the details because I would be overrunning the time. But see, this patient had 5 diopter of cylinder, and we are able to regularize it and bring a 0 correction. This is something which you cannot promise all patients. But suffice it to say that surface ablation, as it stands today, definitely gives us not only ability to correct thinner corneas, but also abnormal corneas. There are a few post-op challenges which are beyond the duration of this talk. But surface ablation, with the detailed understanding of the healing process and the choice of the candidates, definitely stretches our ability to treat refractive patients, surgery patients, on a wider range of corrections. Thank you very much.
Thank you very much, Dr. RAMAMURTHY. May I have a comment?
Yes.
Thank you again for highlighting the surface ablation, because I have a belief that we are back again to the surface because of the modern refractive era that we're having in hands now with the good diagnostic tools. And now I'd like to know your experience between matching the topo-guided ablation, which is Contura, and the wave-front guided ablation, especially that you have both technologies as I see.
Yeah.
The topo-guided ablation, which is Contura in the, let us say, virgin corneas, is so difficult to calculate. Am I right or wrong in this? It needs a kind of astronomic vision or astronomic calculation, while the wavefront is just with a click of a button, you go ahead. Tell me your intuition about that.
We have found it, a PRK Contura, to be making a lot of sense when you're treating higher cylinders. In a routine topography, it is fine. When you're having a higher astigmatism, it definitely seems to make great sense because you're able to map innumerable points on the topography and gives greater precision of correction. So it could be to some extent pushed by the company.
Yeah, and now we have the new trend, which is ray tracing guided ablation, which are looking all for. I will acquire this in a few weeks from now.
Yes.
And I'm looking for the answer of many things that we hadn't answered before, like the epithelial maps and the effect of the epithelium on the as an epithelial lens on the ectatic corneas and the regular corneas.